Greetings. My name is Dr. Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona. This is the 44th annual meeting of the Society of Gynecologic Oncology in Los Angeles, California, and this is Best of the Day. And it's my honor and privilege to be with my good friend and colleague, Dr. Robert Coleman, who is a professor in the Department of Gynecologic Oncology at MD Anderson Cancer Center in Houston, Texas. Rob, welcome.
Thank you, Brad.
This is an exciting meeting, a great time, embracing the past, revolutionizing the future. That is the theme of this meeting, and I really appreciate you taking time out of this busy meeting to chat about some issues related to epithelial ovarian cancer.
Pleasure.
As you know, the standard treatment for epithelial ovarian cancer has been a debulking operation and then intravenous carboplatin and paclitaxel delivered every 3 weeks. A lot of controversy about intraperitoneal chemotherapy. We've been doing this for a decade, off and on. At this meeting, there was an update of the 2 large intraperitoneal chemotherapy trials. Tell us what's new here about intraperitoneal chemotherapy.
Well, you know, you bring up a great point. I mean, we've known about the long-term outcomes from the initial trials of the publication. Very promising. You know, a lot of enthusiasm around those, but we know that there's a toxicity side that we had to deal with. And so I think people maybe who are on the sidelines, you know, wanted to see, well, let's see how this matures out. Maybe it won't be as good as we think it is. Well, what we saw in the presentation today was, you know what, they moved the bar out even quite a bit farther. And we have long-term follow-up, 10 years now, that shows that there's a persistence of this survival effect. You know, 10 months on the median, which, you know, in the current environment, we haven't really hit. And with one of our, you know, adding new drugs to the regimens. And so in that selected patient population of the kinds of patients that we hope to get, optimal, you know, or R0, you know, no visible residual disease, we saw a substantial effect. And I thought that was pretty interesting when we looked at the benefit across that long interval.
You know, one of the things that I do when I see a patient with newly diagnosed ovarian cancer is try to figure out, is intraperitoneal chemotherapy going to be good for her? You talked about the toxicity issue, but I also try to integrate, is it really going to work, and is there an efficacy issue? So here they showed that younger patients do well with intraperitoneal chemotherapy. In other words, it helps them live longer. Better performance status patients, non-clear cell mucinous cell types, low-grade serous. And in fact, it didn't even matter how much cancer was in the abdomen, whether they had complete resection or gross residual disease. So it seemed to work. Is that true?
Across the spectrum.
Across the spectrum.
Yeah, and I think that's actually kind of encouraging, because you remember when the debate started with these new trials as they came out, there was a lot of concern that maybe in that group of patients with who we would have thought would have benefited the most, it didn't really have the great effect there in the previous GOG 104 SWOGS trial. So there was some suspicion about that, but here, clear. Every one of these subgroups, broad spectrum of activity.
And more is better? Is that the idea too?
Well, you know, in terms of
number of
cycles, yeah. I think that was also a very interesting observation is made as well. And I think your colleagues and others had identified that this might be the case in some of the trials, and now it looks like that is true across all these trials, or at least it's supported. That if you can get more of these cycles in intraperitoneally, at least in these trials, it seems to have a benefit in the long run.
And I get it, it's kind of a biased analysis, but I was struck by the presentation that said that if the woman gets 2 cycles only, 1 or 2, of intraperitoneal chemotherapy, I took some notes here, that the 5-year survival is only 18%. 1 or 2 cycles, 18%. If she gets 3 or 4, it goes up to 33%. But if she gets 5 or 6, the 5-year survival is a whopping 59%. So I get it that the sicker patients don't get as many cycles, but that's pretty impressive. So when I now successfully treat a patient with 6 cycles, at least I can think in my mind, she has a 60% chance of living 5 years, I think.
Yeah, well, you know, I think that you're right. There's, I think that there is the inherent bias, and you know, and to be honest, to be clear, that you know, this is a combination of 2 trials that had different, actually modalities of infusion. There are different therapies, different schedules and such. But I think it becomes relevant because there are studies that are looking at ways to try to shorten the number of cycles of the therapy that was given intraperitoneally. For instance, in OV21, they're giving IV as a neoadjuvant strategy and then consolidating with 3 cycles of the IP. And the question is that the right way to do it?
Right. So in summary, 10-year data of intraperitoneal chemotherapy. The survival advantage is more than 10 months, 11 months, works across the spectra of prognostic factors, and if you can get her through 5 to 6 cycles, you can expect a 5-year survival of 60%. Pretty impressive.
Yeah.
So the next thing I'd like to talk to you about is this concept of HIPEC, heated intraperitoneal chemotherapy, right when the debulking is done.
Right.
Tell us how you do that.
Well, right now there's a couple of different ways that it's done, but in generally what it's done is that at the time of surgery and after the debulking is done and you have exposure to the elements of the intraperitoneal cavity, a wash is put into the cavity and it allows the chemotherapy that has direct activity, that doesn't require bioactivation, to directly affect the surfaces of the peritoneal cavity, with the theory being that direct exposure is a good thing. That's what we were hoping with intraperitoneal therapy to begin with. And secondly, that the heated element of that allows for deeper penetration, better bioavailability, and hopefully better cell kill at the microscopic level. So that's the hypothesis.
And how long do they leave it there?
Well, the dwell times change. They're variable, but it could be 30 to 90 minutes depending on the protocols.
So in this particular study, they did a formal phase 2 study of HIPEC, 90 minutes, 41.5 degrees.
Correct.
Tell us what they showed.
Well, it was interesting. They showed, and I agree with you.
It's platinum, right?
It's platinum intraperitoneally. That there was about they updated the results from the abstract at the meeting. That there's about a 20-month progression-free survival and around a 59-month or so overall survival. And I agree with you. I congratulate them for actually doing a formal study because the bulk of the literature that we have in ovarian cancer is usually retrospective experience of people that have adopted the technology. So formal investigation of this is really going to be important. I think it's important because if you think about this patient population that they studied, which was very aggressively treated surgically. I mean, they had a lot of patients with liver resections. 75% of the patients had bowel resections. Is that, nearly the entire population would have been considered pretty optimal. Like there was a 75% R0 rate. They added a few more patients that had very microscopic disease. In that patient population with those survival characteristics, you go back and think about GOG 158, which was paclitaxel carboplatin versus paclitaxel cisplatin in a non-inferiority trial. The PFS was about 20 months, and the overall survival about 61 months. So
why do I need to put it in the abdomen at the time of debulking, prolong the operation, 90 minutes? Why don't I just give her intraperitoneal chemotherapy like we just talked about a few minutes ago?
Well, that's, you can make a case for that. The idea is that if you do it once, and that's maybe all you need to do, then you can give the rest IV, and that's what they did in the study. They gave the rest of it IV for 6 cycles.
So as you know, they're doing phase 3 trials prospectively. And I'm concerned about the control arm because the control arm is HIPEC and then intravenous versus just intravenous. It should be HIPEC intravenous versus intraperitoneal chemotherapy.
Couldn't agree with you more.
And they're not going to win that, I bet. And that's why they're not doing it, I think.
Right.
So we'll have to see.
Yeah.
All right. So we talked about intraperitoneal chemotherapy. That's one emerging treatment, although we've been talking about it a long time. The other one is adding a third agent. We've tried cytotoxics, it doesn't work. But adding now a targeted agent, bevacizumab, I think our audience is familiar with GOG 218, published in the New England Journal over a year ago, which showed that when bevacizumab is added to Q3-week intravenous chemotherapy with maintenance for total duration of 15 months, that the improvement in progression-free survival is 3.8 months. Is that good enough? I don't know. And so here at this meeting, there was some subset analysis and some updates of that GOG 218 that I think are pretty interesting and pretty informative. And you were, primary author on one of those. So tell us about that.
Well, I think what we were interested in is that over the course of these multiple presentations of 218 and of the ICON 7 trial, was that there was felt to be potentially patient populations that may benefit better or more to a higher degree, especially as it becomes irrelevant when you talk about toxicity trade-offs. So you want to take the big maybe you would take the toxicity in the setting of a big outcome in progression-free survival, overall survival. So what we saw was that in both of the trials there was a suspicion at least one subgroup seemed to do quite well. You know, the first word we got of this was a high-risk subpopulation of stage 3C and 4, the suboptimal stage 3Cs and 4s that were operated or that participated in ICON 7, and that showed this overall survival benefit in that subgroup, which they hadn't seen in the bigger population.
Bulky disease, but only in the ICON 7 study.
Right.
Okay.
So then in the 218 population, which was much larger, as you know, because it included predominantly suboptimal patients to begin with, and then it was allowed to add the optimal visible patients later. We tried to reproduce those results by using that same eligibility criteria. And what we found was that in that same subgroup of patients, we really didn't see the big benefit in overall survival. Big difference in progression-free survival, even bigger. But we did not see a big difference in the overall survival. But within that group, the stage 4 patients, which is about 300 and change patients, we did see an overall survival benefit, or at least the hint that there might be something there. So again, with all of these studies, and since those are unplanned analyses, they raise hypotheses. And I think that's what we're getting at, is that maybe there are specific subgroups that may benefit. And fortunately, we've got the studies already underway to help us sort those out.
So in the European ICON 7 trial, published at the same time in the New England Journal, there was a suggestion of a survival advantage in those patients with bulky residual disease or stage 4.
Right.
You looked at 218, same thing, okay? Couldn't see the bulky disease overall survival advantage, but you did in stage 4. Is that what you said? So in 218, GOG 218, if patients had stage 4 disease and got BEV, they lived longer?
Well, there's the idea is that that's what we saw is an association. So, but again, it's, with these kind of analyses, we have to be careful about how over-interpreting. And of course, you remember in the study, the way it was originally designed, they accounted for multiple comparisons. And these, I'm not sure exactly how well those were controlled for. In the
and how much longer, again, in this hypothesis-generating unplanned subset analysis?
I don't remember.
8 months.
Yeah.
8 months. Okay, okay. All right, and then the other thing that was interesting about GOG 218 was some of the ethnicity and age-related differences. So there was an abstract by this woman who says that if you're Asian, you do better. Can you?
Well, this is actually, I think, opening up a new world for us. Yes, the idea was to go back and look at age and race, and we know that age is clearly a prognostic factor. We've seen it over and over again. The race side of things is actually quite interesting because it's not just in ovarian cancer. We've seen this across the board in a number of different solid tumors, lung and others, for which there may be some pharmacogenomic differences on how certain drugs work in different patient populations. So, it's interesting because there may be, what we don't have a clear answer on is what are the exact biomarkers, for instance, that might predict who might do well with a drug like an anti-angiogenesis drug agent. But we do know that in certain patient populations, some of these patients have higher degrees of cytotoxicity. They may have off and on-target effects that are at higher rates. And so it may be that the same biomarkers in different patient populations may portend a better outcome.
So these issues, to be clear, ethnicity doesn't predict better activity of the anti-angiogenesis drug. It just predicts better outcome, period. And the difference was among the improvement. The better prognosis was among Korean and Japanese women that lived in Korea and Japan, not necessarily women of Asian descent that were American. So ethnicity, I think, plays into it, but it may be diet, some of these other environmental issues, but clearly there seems to be differences in the prognosis based on, I guess, where you live and your ethnicity.
Yeah, I think.
I don't know.
I don't know. I think that there are. There's probably some interplay of the two, but then again, a lot of these are cofactors, so that the involvement of the many of things together may actually present. But I have a feeling it there is some merit to the value of the thought that agents have a different type of modulating effect in different patient populations, and I think that needs to be sorted out further.
And the other thing that she did is she talked about age, and we all know that if you're over 70 and you get an advanced ovarian cancer, you're going to do much, much worse than a younger patient. And again, I took some notes here, but the risk of death over the age of 70 is 47% higher than if you're less than 50.
Right.
So we need to do a better job in geriatric oncology, particularly in ovarian cancer.
Yeah, and I think that raises a whole lot of additional issues about like tolerance of therapy, number of cycles,
Right.
and then of course survival in that age group. You need to. I mean, there's already a background rate of
Right.
higher death rates anyway, so it needs to be teased out as to what is disease specific and versus other.
So the next controversy regarding Bev is maybe we should use it second line.
Yeah.
When you use it front line, it's more expensive. It's actually less toxic, but so there's these two trials in recurrent ovarian cancer. One's called the Oceans trial, where Bev is added to carboplatin and gemcitabine, and that's in sensitive patients. And then in platinum-resistant patients, it's added to one of 3 chemotherapy backbones: liposomal doxorubicin, topotecan, or weekly paclitaxel. And in both randomized phase 3 trials, there was an improvement in progression-free survival with the addition of bevacizumab compared to chemotherapy alone to 0.48. So a hazard ratio reduction of half for progression-free survival.
Right.
So at this meeting, the resistant study, the Aurelia trial as it's called, was updated regarding some of the disease-related symptoms. Tell us about that.
Well, I thought this was an interesting analysis because I think at the original report we saw some information about the toxicity profile, and then we were concerned, for instance, in the liposomal doxorubicin arm, that the hand-foot syndrome, for instance, which requires some innate repair process, might be accelerated, and that neuropathy might be accelerated by the use of a drug like this. And so I think what we saw in the study is that there were actually several side effects that were higher in the patients who didn't get it, although these neuropathy and hand-foot syndrome were higher than expected, or were higher than the control arms. But then what they did in this study, which I thought was what we really want to know, you take symptomatic patients and you provide them an intervention and you see what happens to them over time. Because as you know, it's hard to make an asymptomatic patient less asymptomatic.
Right.
So you take a group of symptomatic patients, ascites, and you treat them with an efficacious therapy. What happens to their symptoms over therapy? So you have competing interests. You have resolution of disease and you have side effects from chemotherapy. And so what was interesting across a number of parameters is that we saw that these patients that were on therapy, there was essentially a modulation of the fact that the reduction of the disease-specific symptoms and the accumulation of toxicities due to the therapy were kind of balanced. And actually, in some places, they actually got better over time. So I think it gives us a new perspective on the use of biological or effective biological therapies in a patient population that we really haven't had a good handle on. This was the symptomatics.
And I love this trial. This is the first positive randomized phase 3 trial in platinum-resistant recurrent ovarian cancer.
Right.
First time. And it's interesting because patients got more treatment in the more effective bevacizumab arm.
Right.
The chemotherapy-related symptoms are exaggerated. Hand-foot syndrome and neuropathy specifically. But because it's more effective, the disease-related symptoms got better, the abdominal pain, the nausea, and the ascites.
And again, we don't have a good database of that.
It's a balance act.
Right,
though.
exactly.
So,
right.
So I won't put you on the spot, but it's a classic question today when you see a woman with advanced ovarian cancer. Do you use it up front or at recurrence? Lots to consider.
Yeah.
I'm more of an upfront guy. Based on the tolerability and the magnitude of the benefit, but I think there's a lot of controversy here, and cost is a big factor.
Right.
The thing that we've learned, though, for sure, is that bevacizumab is pretty well tolerated. You use it up front. You can use it in resistant disease with those 3 single agents. You can use it in sensitive disease with carbogem. And then here, now they're adding it with everything. So here at this meeting, there was a small study of irinotecan. Tell us about that with Bev.
So this was a study that was essentially unlimited priors, and they actually didn't restrict for prior irinotecan or prior bevacizumab. And there was a proportion of both of those exposures in the treatment plan. So they're heavily pretreated, and of course that always makes us nervous to give bevacizumab in that patient population, knowing our experience of growing up with the drug.
Bowel perforation.
Bowel perforation,
increases,
exactly.
Right?
So what they did in this study was to add it to irinotecan, and there's some good reasons for that, which I'll get to in a second. But basically what they showed is that they had a pretty high, maybe better than expected, clinical benefit rate, which includes both the responses, which was reasonable, and the stable disease rate. And so they ended up in that 50-60 ballpark range. which we've seen with with other anti-agenesis type drugs with chemotherapy in single-arm phase 2 trials. But I think what's really interesting about this drug, and I do like this combination, like I also like weekly paclitaxel bevacizumab, is that irinotecan falls into a class of drugs that we know activate another anti-agenesis mechanism, the HIF-1 alpha pathway. Right. So it's very complementary to the anti-VEGF strategy to use that with an anti-HIF-1 alpha inhibitor. So I kind of like it, and if it's tolerable, which this has not been an easy thing to take, the combination, and actually they had to do a dose modification in their first 6 patients. It's not uncommon to see with this particular class of drug. But I do like it. It makes sense from a biological standpoint. 175
is what they reduced it to every 3 weeks. I like it because you've said that patients with ovarian cancer are living longer, and they're getting lots of different lines of therapy. And you could run out of active agents very quickly. You run out of carboplatin paclitaxel, weekly paclitaxel PLD, and GEM in some sort of combination with Bev. So that's not 6 or 7, which is what our patients are getting. And so the next one would be a topoisomerase inhibitor, topotecan. It's inconvenient, 5 days. So this is a topoisomerase inhibitor, and this is a nice combination because in this palliative setting, it can be given every 3 weeks. And so the tolerability, a new agent really because patients are getting lots of different combinations. I liked it too. Not very many patients, but still, response rate of over 20%. I want to finish here with 2 concepts. One is to talk about PARP inhibitors and also about what patients think, because heaven forbid we actually ask what the patient wants. But PARP inhibitors are exciting. I think the audience knows, limiting this defect in homologous recombination repair. Part of the challenge with PARP inhibitors is that they've been too toxic to add to chemotherapy, particularly olaparib, which is in the furthest development. But at this meeting, there was a phase 1 with a 1B expansion of adding olaparib to carboplatin. And why carboplatin? Because it is a DNA damaging agent where its effect could be improved or exaggerated with PARP inhibition. Tell us about that and whether you like this idea of giving olaparib with carboplatin, or whether you think olaparib in the future is probably better as a single agent.
Well, I think I do like the concept of DNA damaging agents, and I think that there's a lot of history and story that we can get into. Probably don't have time for, but I think what was interesting about this particular combination is that when you add it to a drug like platinum that can cause make the vulnerability more relevant. It has an effect, and of course they stacked the audience here. They looked at patients who had germline mutation, and they also looked at high-grade serous, and we hope that that's the case. That audience is maybe 50% of our patient population that have a vulnerability in homologous recombination. So combining the two to improve outcomes, I think is a good strategy. And I think this trial helped to show that, because in platinum sensitive, they both have activity. They're better in platinum sensitive. Platinum's better in platinum sensitive. PARPs are better in platinum sensitive.
So let's use them together.
So let's use them together. But they used them in resistant patients, and they still got responses.
Right, when platinum shouldn't work.
When platinum shouldn't work. And actually, when PARPs generally don't work either, as we've seen with olaparib. And of course, the combination also leads to dose reductions on both of them. So, but they were able to find a way, which is a pulse way, of giving it for 7 days with the platinum every 3 weeks, and they were able to come up with a way to give the strategy in that manner. So, there's more work definitely to be done here. I think the big relevant question is going to be, how do you get it approved?
Well, and to the point, there's no phase 3 randomized trial that's enrolling. There's a few in discussion, and I know you're involved in those, but I'm a little disappointed that we haven't even been able to start a phase 3 trial, because we've been talking about PARP inhibition for a long time, and all of these issues, synthetic lethality, single agent with chemotherapy, what's the right patient population, and then the toxicities, marrow suppression really, that we've talked about. So. There are other PARP inhibitors. You're involved in one that's also presented here. Tell us about that study.
Yeah, so this is going to be a presentation that's coming up later this week on looking at veliparib, which is another PARP inhibitor that has a profile that's similar to olaparib, at least with regard to its cytotoxicity. And so we did this in patients who had recurrent disease, and we were looking for the BRCA patient population, and we were looking for objective response only. So we were, although we think that there's probably a benefit to delaying progression, we felt that because a lot of subsequent trials, especially within the GOG NRG, is banking on the activity of this, we wanted to do a single agent in patients with measurable disease to see if there were responses. And so I'm happy to report that we were able to at least clear the minimum of number of responses of this essentially trial, which has been closed, but where it had accrued so rapidly that we haven't had enough time for even patients to have subsequent follow-ups. But we do have enough confirmed responses to clear the minimal target zone of efficacy.
Almost 20%, but it's a very unstable number. So,
right, it's right, yeah. So the lowest it could be is that.
Right.
So as I mentioned, there's maybe 20 patients who haven't even had serial assessments.
So this is exciting because this drug, also known as ABT-888, it's within the CRADA mechanism.
That's
right. Within the CTEP organization. So the cooperative group mechanism is also doing a phase 1 to add it to frontline chemotherapy.
Correct. That's right.
So we talked about the controversy, single agent versus combination. This drug, it can be added to chemotherapy because that phase 1, although not reported, we all put our patients on them. And ultimately the GOG or this new Energy collaborative group is probably going to do a frontline PARP trial with this Vlaparib ABT-888. And so showing that this was active as a single agent was a necessary, mandatory step. And we're excited that it shrank tumors.
That's right.
So it's great.
Yeah, so we're excited that we're...
Congratulations.
Thanks.
So actually 2 of these papers that I've talked about today, you're first author, so this is great. And then finally, the third paper is that you're involved in is to survey ovarian cancer survivors. And just to ask them what's important to you. Because we talk about response rates, we talk about toxicity, delaying progression, stable disease, and cure has different meanings to different people. But tell us what patients want in your survey of over 1,000 ovarian cancer survivors.
we were amazed. So, this debate, we've had lots of conversations about what's the role of progression-free survival, what does it mean, and it has generated a lot of controversy in our medical literature. I mean, we debate about it. It's in print, and I always felt, I don't know, I just kind of felt like the patients never really had a voice in the debate. And I thought, what's a way we could, unscientifically, but maybe we can come up with some way to just poll patients and see what they think. Ask them. So we went to the Ovarian Cancer National Alliance, their annual meeting in July in Washington, D.C., and we said, hey, we're going to put a poll out on your website. Feel free to access it. Tell us what you think. So we were amazed. 3 weeks on, we had over 2,200 hits. 1,400 people filled out, so at least some part of it. Over 1,000 complete with data points and comments in the 28 question survey. So what was interesting is that what we tried to capture was outside of the user demographics was to see what they wanted in terms of outcomes, what would be meaningful to them, and would they trade high toxicity for outcomes. And so what we found was essentially that under these hypothetical case scenarios was that patients really wanted decent outcomes, and we probably underestimated what was the trade-off point. We went like 1, 2, 3, 4, 5 months or more. They all picked that no matter if it was progression-free or overall survival, they wanted to see 5 more months. So we said, okay, well that's good, but let's say we amp up your toxicity to get that endpoint. And as it turned out, they would rather take more toxicity to have 5 months in overall survival gain than to have a no overall survival gain. In other words, just a PFS gain and no toxicity. But what I thought was actually quite interesting is that about a third of people said, listen, neither one of those are acceptable to me. And so we, in trying to tease out that data further, we started to go back to say, what kind of side effects do you consider intolerable? And what we found was that patients that are on frontline therapy will take a lot of toxicity.
Right.
But when they recur, they're 2 to 1. They wouldn't take the toxicity.
The difficulty that I had, though, is that everyone's unrealistic. So if you ask me, how fast do you want your car to go, I'm going to say 300 miles an hour, but that's not realistic.
Yeah.
So you have to couch this into practicality. So I get it that they want 5 months, but is 2 months a value. In other words, if two's all you can get,
right.
if it's 0 or 2,
right.
if it's versus walking versus going 50 miles an hour, then is 2 months something that you're going to so it's difficult to really figure out what patients really value.
Right. So, and what we wrote, the way the question, the hypotheticals were written, and we had to describe what these endpoints were.
Right.
You know, I had to define them so in lay language so they understood it. But we asked them what was the minimum that they would accept under these scenarios.
So that's good.
And so, but you're right, because one of the other things, the caveats, and this is a learning process, and it's why we need to have this dialogue going forward about how do we capture these endpoints well, is that patients who have experienced the side effects have a better interpretation about what it means to them to have, and so they may say, "Listen, I really don't want that." And we didn't really capture that very well, and of course, it's hard to scrub that kind of data when it's just basically anonymous and voluntary, but. It did actually help me point in a way that patients they want to be there, and so what it's gone now. What we were following this is that we've been to the FDA with the SGO, and we are developing a white paper, as you know, and you're helping us to develop, to essentially try to put all of ovarian cancer management into some kind of context, and then also add that patient-reported part out of it into this document and bring them to the table, and to help us. And hopefully help all investigations going forward to come up with better, endpoints that mean something.
Right. So, Dr. Robert Coleman, this has been fantastic. I love your perspective, and I'm very proud, actually, that many of the abstracts that we discussed, you were either a co-author or even a first author. Yeah. So I appreciate you. I also would like to personally congratulate you for being elected president of this society in 2 years. So we do it 2 years in advance, and so that's a great honor. It could not have been better deserved. We're looking forward to the meeting that you preside over as president, and it's been my pleasure. So this has been Best of the Day, the Society of Gynecologic Oncology in Los Angeles, California. So long for now.